one, go.
Hearty and happy welcome to all of you. We are back again with our Safog series, and it's my pleasure to welcome you here for today's session, 19th of January, 7 p.m. We'll begin this session with our prayer and lighting of the lamp.
Ankurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam dhanasampada shatrubuddhi vinashaya deepajyotirnamosute shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
So I welcome all the delegates and participants who joined for this webinar. Now let me introduce our MOCs, Dr. Niharika Malhotra and Dr. Shehla Jamal. Dr. Niharika Malhotra, ma'am, is a consultant in Rainbow IVF, and ma'am is a chairperson of Foxy Young Talent Promotion Committee since 2022. Ma'am is joint secretary of Foxy in 2018 and assistant editor of Journal of IJHRRD. Ma'am also have lots of active memberships. Plus, ma'am has been awarded with lots of awards. Now, let me introduce our another MOC for the day, Dr. Shehla Jamal. Ma'am is the founder and president of Society of Menstrual Disorder and Hygiene Management, and ma'am holds the India Book of Records holder. Ma'am is also secretary of GNOGS, chief editor and journal of reproductive and menstrual science, and ma'am is also social activist and writer. So I welcome both the MOCs and I hand over the session to Dr. Niharika Malhotra, ma'am. Thank you, ma'am.
Thank you so much, Nishant. And thank you to Team Safog for having me here regularly on these Safog international webinars. I really enjoy these sessions of learning and interacting with all of you. So we yet again here with another wonderful session on cosmetic, aesthetic, and regenerative gynecology. I welcome Dr. Naren Malhotra from India to give the welcome address for Safog International Oration webinar today.
Very good evening to all of you. It's indeed a pleasure to invite you and welcome you to this Safog International Oration series. Last year, we had the webinars every 2 months on a subject with a panel discussion. This year, we're going to have 12 international orations, and we start with none other than the topic of cosmetic gynecology, which is so much being talked about, so much in news, and whether we require and filled with controversies and everything, should be doing it, should not be doing it. And we have none other than my dearest friend, Dr. Red Allensod, for taking you through the journey of cosmetic gynecology. I welcome all the Safog office bearers, all the registered delegates, and I'm sure that you're going to enjoy the lovely scientific deliberation and the fantastic videos on what we can do with energy-based devices and the other things. So thank you very much for attending this. Welcome to this great webinar.
Thank you so much, sir. And with great pleasure, I would now like to invite Dr. Rohana. And I recently met him last week, and it was such a pleasure to have you here with us in India, sir, in Calcutta especially. I welcome you today for your presidential address. As we all know, Dr. Rohana is the president of Safog. He's also the vice president of Saforms and has been the past president of Sri Lanka College of OBGYN. Welcome, sir.
Thank you, Niharika, for that kind introduction. I'm very happy to see you again moderating this webinar for us. You have been a great moderator to our webinar programs, which are really well moderated. So thank you. Now, good evening to everybody, and good morning to Dr. Red Allensod, who is from USA. I suppose it's early in the morning, to Dr. Allensod. So first of all, I also welcome all the participants who would have joined this very important, very novel oration which we are going to witness today. So firstly, I would like to thank Dr. Narendra Malhotra, who is our really energetic director of international affairs in Safog, who really conducted so many webinars, very, very successful webinars with other international organizations like PIGO, RCOGs, A4G, and so on last year. And now here, this year, he has come up with this another one of his attractive programs, that is these orations. So today we are into witness the first oration. So for that, he has chosen a very important subject, which is very new to me, of course, as we have not heard very much and we have not discussed these things in our sessions and academic programs. So we are very happy that Dr. Ed Alinsford, who is an expert in this field, is here to talk to us on this subject. So I also like to thank the chairperson, Dr. Ranjini Agrawal, the Professor Farooq Saman, I suppose he'll be joining, and Professor Farhana and Dr. Ratnasiri, all from Safog, and Dr. Ranjini Agrawal for chairing these sessions today. And also later, I think Dr. Yusuf, our Secretary General, will be delivering the vote of thanks. So thank you for everybody. I won't take any more time because we have to listen to this excellent oration. So thank you, and I pass you over to Niharika.
Thank you so much, sir. And let's begin our scientific session. And I would now like to invite our chairpersons for today's session. First chairperson for today's session is Dr. Ragini Agarwal from India. She is the president of Indian Society of Aesthetic and Regenerative Gynecology, INSAR, and also the president of Indian Academy of Cosmetic Dermatology and Gynecology. She's also been the vice president of FOXY 2020, founder president-elect of North India Gynec Forum. We welcome you here, madam. We also have with us Dr. Farooq Zaman from Pakistan. He is the Dean of OBGYN at Rashid Latif Medical College, Lahore, a gynecologist and a fertility consultant at Hamid Latif Hospital, Lahore, and has more than 36 years of experience in his field. Welcome, sir. We have with us Dr. Farhana Dewan from Bangladesh, President-elect of Society, Deputy Secretary General of Safog, Head of Department of OBGYN of Sina Medical College, and Professor of OBGYN in different medical colleges in India. We also have with us Dr. UDP Ratnasiri from Sri Lanka, Consultant OBGYN from Castle Street Hospital for Women at Sri Lanka, Treasurer for Safog, Chair of MFM Committee of AOFOG, and Chair of IRC RCOG Sri Lanka. Welcome, sir. So I would now request our chairperson, Dr. Ragini ma'am, to please introduce our speaker.
Hello. Very good evening to all of you. Thank you, Niharika, for your kind introduction. And thank you, Malhotra sir, making me the part of this great event. So now today's speaker is none other than Dr. Red Ellison, who is a big name in the field of the cosmetic gynecology. Can I have his CV? So Dr. Ellison is from USA, and he is a South Coast Urogynecology NC founder, and we all know for his great input in the cosmetic and aesthetic gynecology. He has the Ellison Institute for Aesthetic Vulvovaginal Surgery and Gynefix Cosmetic Gynecology e-learning. In many conferences, we have seen him and we have read books authored by him for our development in the cosmetic gynecology field. So I will not stand between Dr. Red Ellison and you. Welcome, sir, for your deliberation.
Well, thank you very, very much. What a pleasure to be here with you. When I got this invitation to speak with Asia, I was just so excited because I don't get this opportunity much. I've been to India, but I've not been to most of the countries represented here. And my goal in the future is to personally meet each and every one of you and visit your countries, and hopefully we can share knowledge together and expand this field. So thank you very much. Should I just go ahead and start with my talk?
Yes, please. Yes, please.
All right. So I'm going to go ahead and put my talk up. Let me see here. Can you see this okay? Hopefully. There you go. Well, I'm going to go ahead and spend the next 45 minutes or so, somewhere there, and talk to you about cosmetic and regenerative gynecology. Most of you have not been introduced to this topic, so I want to give you a brief history. I've condensed this talk down so I can get it all in. First, a little bit about me. I graduated from Loma Linda University School of Medicine in 1986. And I was in the Air Force for several years, and then I went into a group practice for 10 years. And then the past 18 years, I've been in a solo practice here, dealing with aesthetic gynecologic surgery, doing research and development on energy-based device, and more recently working with biologic products. So this is my invention and devices and patents. Just to give you my non-disclosure, I'm the inventor of a sling with bladder support, Lone Star retractor. I have the patents on the pelvic mesh devices in the United States. And also I invented Thermiva and predictive permeation for gynecologic conditions. And so those are some of my developments in the past. And more recently, I've been working with carboxytherapy for gynecologic use, and also vaginal diode and infrared lasers for home use, and O2 VASC to increase localized clitoral blood flow and amniotic fluid. And more recently, we've been working on exosomes for gynecologic conditions. I've been teaching workshops, both surgical and non-surgical, for almost 30 years now. And more recently, I started Gyneflix, cosmetic gynecology e-learning. So for those of you who live far away and can't travel to the United States, I put all of my learning videos, over 200 detailed 4K videos. I'll tell you more about it later, but you can learn this from your home and from your office now. So gyneflix.com, I started in October, and now all of you all around the world can learn on with my videos. So first of all, what's aesthetic gynecology? I'm going to answer and tell you a little bit about energy and biologics. I'm going to show you surgeries that are part of aesthetic gynecology, and also introduce you to my Gyneflix e-learning. So what's aesthetic gynecology? Well, you know, it's the fastest growing segment of plastic surgery in this past decade. More and more plastic surgeons, dermatologists, and gynecologists are entering this field. And it used to be only doing things like labiaplasty, vaginoplasty, hymen repair, but now it includes energy-based devices and regenerative medicine, and also menopausal management. So this is the problem. Aging and gravity results in all these conditions, such as overactive bladder, vaginal dryness, and fecal incontinence. These are all the problems that the women are facing here and abroad. They want to regain their youthful function. They want to look good again down here, and they're willing to go outside of traditional medicine to find people who are interested in this and can help them, and not just with traditional medicine, but with the more modern techniques and procedures that we're doing. It's very controversial in the United States. First of all, the American College of OBGYN in 2007 came up with this number 378, I think it was like a committee opinion, and they said this area was not medically indicated. They said safety and effectiveness were not well documented, and there's lack of data. And so they discouraged us when we were starting this field from moving forward, because they didn't like the words rejuvenation and cosmetics. It's not in our DNA for OBGYNs. So they said there were problems with ethical concerns, marketing, they didn't like the idea of franchising, and they live in a world where insurance is king, and being an entrepreneur in this field was looked down upon. The business model and the control of dissemination of knowledge they thought was very troubling. So they just did not like this idea of cosmetic gynecology in 2007. And so they also said it was it's potentially a deceptive practice, that people will think that it's a normal thing, that it's accepted, and the absence of data really bothered them, and they thought that some of these treatments may traumatize the patient, because these are, quotes, unproven surgical procedures that were being done on some of these patients. So because of the lack of data, they said, don't really go into it. So that they were trying to halt the progress of this field. Now, even in a few years ago, the American Board of OBGYN, this is not well known, sent a letter to many board certified gynecologists who were performing aesthetics. They said that if you were performing more than 50% of aesthetics in your practice, and that you were treating men, for example, some of the aesthetic gynecologists were treating men with hormones, or treating men with erectile dysfunction, they threatened to remove our board status. All of us who have passed the board, who are doing aesthetics, were threatened to have our board status removed in the United States. And so Dr. David Matlock, one of the founders in this field, a good friend and very supportive person, wrote a letter to the boards saying that we passed all the requirements that you had to get our board status, and you're restricting our trade, and you're colluding with American College of OBGYN, are you? Who told you to restrict our trade? And so this potentially became a huge media event in the United States, and the case was dropped by the American board. And now let's go 10 years later, 12 years later, in June of 2017, the American College of OBGYN changed their attitude a little bit, not tremendously, but they became a little more positive. They said you should focus on counseling, do a body dysmorphic disorder workup. And they said credentialing, education, training, and experience were now important. So instead of just saying, no, you can't do this, they said, go get trained. If you have the credentials and you get trained, patients can make autonomous decisions, and surgeons such as I can then offer these procedures that first, in the past, just 12 years before, were a no-no. And so now we can actually talk to patients about this. But there was no commitment to train residents, no commitment to train fellows in obstetrics and gynecology. And so plastics and cosmetic gynecology, plastic and cosmetic specialties and dermatologic specialties embraced it and are slowly taking this out of the OBGYNs. History was repeating itself. Tummy tucks, breast implants, liposuction, laparoscopy, all invented by gynecology, were now being taken by other specialists. And elective procedures such as labiaplasty and vaginoplasty, lasers, and other regenerative options were going to the other fields. And so they were going to plastics, cosmetics, derms, even primary care, and away from OBGYN. And I feel it as a goal of mine to help this practice come back to gynecologists and expand our field. Now, this is not a new specialty. This has been around for over a decade. I started giving yearly meetings back in 2006. The Congress on Aesthetic Vulvovaginal Surgery started in 2006, and I ran this for a decade. That was a yearly meeting here. In Australia, Dr. Peter Petros and others had ISPP, and here are some of the other meetings all around the world. And it started really growing right here in 2015. There was an explosion of growth in 2015. So this is not a new specialty, okay? It's a specialty that's expanding to different specialties such as plastics and primary care. In Europe and other places, Dr. Bader headed up the European Society. And now this topic is even being addressed in some mainline meetings, such as the Laser Society, the Laparoscopy Societies, American Urologic Societies. And now there are some university-based training programs that are starting. There's a university training program, I believe, in India. One of your colleagues there has started that. Also one in Barcelona and one in Buenos Aires, Argentina. It's growing. Asia, Europe, Latin America, Middle East. It even has special subspecialty status in a couple countries I know about. And India is one of the leaders in this field. And that's why I love speaking to my Indian colleagues, because you guys are really helping expand this field more than any country I know, more than here in the United States. You guys are leading the charge, and I'm very, very proud of my Indian colleagues there. The United States, this is where it all started, is about a generation behind. And I believe, at least in growth and dedication to this practice, India is the #1 country in growth of this specialty. And I hope you guys continue that. So ACOG, American College of OBGYN, has diminished influence, and the specialty is leaving traditional gynecology, at least here in the US. The horse has left the barn, and now innovation comes from private physicians and not from academia. The academic institutions, at least in the United States, are a decade behind and still, by and large, making fun of this specialty or not accepting of this specialty. Now, there's a lot of technology that are out there, but I just want to focus on the main things. Lasers and radio frequency are the core devices, at least here in the United States. There's others, such as HIFU. There's injectables also, platelet-rich plasma, and the O shots. There's fillers, hyaluronic acid, and fat. But I'll concentrate on radio frequency because that's my field of interest. And then I will leave things like CO2 lasers and erbium lasers developed by friends of mine, Stefano Salvatore in Italy, Adrian Gaspar in Argentina. We'll attack that topic on a separate talk, because this is a whole hour by itself. So I will concentrate on this, the radio frequency treatments that I help bring into the United States and introduce into the world. I started using this in 2009 with a device called Pelave way back then. So starting in 2009, I started working and developing this device right here, transcutaneous temperature controlled radio frequency, a little device that created radio waves right on this tip, very small. I did a TV show in the United States, and I introduced it to the United States on a show called The Doctors. So it was born in California, researched in Massachusetts, in MIT, and manufactured also in Texas. And then we launched this in 2015. That's when all the growth of all these devices exploded. And so let me tell you a little bit of what these things can do. Those who have not heard of this, it's a tiny device that's about the size of my finger, and it's able to treat the external labia and introitus, and also to treat deep inside the vagina to increase the blood flow initially. So what are the effects of radio frequency on tissues? It denatures collagen if it's hot enough, and it causes a contraction of fibrils to give a tightness. And it also then increases the collagen and elastins, and the tissues can thicken. It activates the healing cascade and helps new collagen to be formed. New vessels are formed. And also, when you use radio frequency energy, there's an increase in elastin, and elastogenesis is seen. I have not seen this in lasers, but it's definitely seen with radio frequency energy. And also, really important, we found that there is neurogenesis and stimulation and increase of the small nerve fibers when you use a low kilohertz device below 1 megahertz. Stay in the low kilohertz, and you may be able to help the nerves. So in the United States, radio frequency is approved for dermatologic conditions: loose skin, thin skin, dry vulva, insensitive skin. It's even approved for surgical indications like electrocoagulation, hemostasis, and nerve ablation. And you notice it is not approved for vaginal rejuvenation, okay? It's approved for these dermatologic conditions. In Europe, it's approved for vulvovaginal laxity. You can actually have this indication in Europe, but not the word vaginal rejuvenation. The term vaginal rejuvenation really is not in textbooks. It's more a lay and marketing term developed by my friend, Dr. David Matlock. But it has gotten worldwide attention, and a lot of even scientific organizations call it vaginal rejuvenation. In 2016, we came up with our articles, and also this important article by Dr. Wilson. And what these two articles were able to show was that you can increase the thickness of mucosa. You can see the difference here. You have an increase in thickness of the mucosa. You have denser stroma. Here's a before treatment and after treatment with radio waves, the stroma gets denser. There's an increase in elastin and collagen. You can see the increase in the bluish coloration in this area. But really important is that there was an increase in small nerve fiber density. And this small nerve fiber density is probably why you have seen improvement in things like overactive bladder or orgasmic dysfunction. So it's really important that you treat this whole complex, not just the tip of the glans clitoris, but actually this whole complex. You treat the entire vulvovaginal area, and you can potentially increase the sensitivity and improve sexual function with these patients. But that's just one thing. It can also help many things. Now, let me show you some of the things that radio waves can do. This is the article I published in 2016 showing that radio frequency can help with orgasmic dysfunction, and with treatment, you can reduce the time it takes to be sensitive and to be orgasmic by anywhere from 1/3 to 1/2. So instead of waiting forever to achieve sensitivity and orgasms, it's reduced in time, and it helps many, many women. It doesn't help everyone, but it can help those with these issues. And what else can radio frequency do? And lasers also. Lasers can also do this. They can tighten skin. Here's a before and after. And after 3 treatments, you can see the dramatic tightening. So the improvement in appearance, and also not only in appearance, this skin is now thicker with more collagen and elastin. It's not rigid. It's not easily irritated. And this is all without estrogens. Of course, you can use estrogens and keep the thickness, and you can keep the elasticity, but estrogen alone will not give you the improved appearance of the tightening of tissues. So in 2 months of treatment, you can also see here that an area that's previously dry now is producing moisture. You can see this discharge, this transudate. You can really improve a patient with severe atrophy and improve the formation of new moisture in about 2 to 3 months. You can also shrink mucosa. For example, here's a patient who really doesn't want to have surgery, so she just wants to reduce her symptoms. She's not concerned with the appearance of the bulge, but she just wants to reduce her symptoms. So now you can actually treat this area with radio waves and then give a modest shrinkage of tissue and reduce symptoms. If your goal is symptoms reduction, you can use lasers, you can use radio frequency to help reduce the symptoms. After 3 treatments, you can have dramatic reduction, and it's reproducible over time. For example, here's a patient of mine, and here's a 3-year history. 2015, she has a modest to severe prolapse of her bladder. Here's 2015. I did 3 treatments, and then I touched it up in 2016 with a single treatment. You can see there's shrinkage of tissue. She comes back a year later, 2017. You can see her symptoms are improving over time. And in 2018, look at that, it's almost gone. So it's an additive effect over time, and you can reduce the symptoms for patients who don't want to have surgery. For those with stress incontinence, you can also shrink the mid-urethra. You can see here before, and then after, there's a modest amount of shrinkage. So those with mild to moderate stress urinary incontinence, you can reduce your symptoms. It doesn't work very well in severe incontinence, and I wouldn't recommend lasers. I wouldn't recommend radiofrequency if they have severe incontinence or intrinsic sphincter deficiency. But for mild to moderate, you may be able to help them. But it doesn't last forever, unfortunately. You have to keep touching it up every few months. I recommend every 6 to 12 months of a single treatment to keep this area shrunk down. So this is where you want to shrink tissue. Now, for overactive bladder, this may be an even better treatment than your anticholinergics, and even the InterStim device can be reduced in its use by using radio waves. Because what I found over this past decade is that radio waves can help mild to moderate stress incontinence, but also overactive bladder can be reduced by 1/3 to 1/2, and oftentimes it can go away. And it's even better when you add things like platelet-rich plasma or amniotic fluid injections and combine energy and biologics together. You can really help patients with overactive bladder. and get rid of the anticholinergics, get rid of the dry mouth, get rid of the constipation and the occasional dizziness and passing out. So it's wonderful for that. The other things that lasers and radio waves can do is reduce the pH down to normal. Most of the menopausal patients are at pH of 6 or 6.5, and with regular use, let me go back here, with regular use of lasers or radio frequency, along with, let's say, estrogen cream, you can really get the pH back to normal. You can normalize the flora and the fauna and reduce UTIs and vaginitis. Also, you can use it for transanal treatments. Right here, you can see the wand going transanally, and you can help with fecal incontinence, flatulence, and it can give you a modest amount of anal tightening for our homosexual population in Los Angeles, Beverly Hills, New York. There's a lot of treatments going on transanally with these radio frequency devices. All right, so now we'll switch a little bit and go to regenerative therapies using these things right here. Started by Dr. Reynolds in Fairhope, Alabama. Platelet-rich plasma is being used now for stress urinary incontinence, overactive bladder, orgasmic dysfunction, lichen sclerosis, vulvar vestibulitis, and even dermatitis. And so PRP originally was made and tried for sensitivity in the gynecologic world when Dr. Reynolds came up with the O-shot, the injection of platelet-rich plasma into the clitoris and G-spot areas. And now it's been expanded to be injected in the vulva, into the perineum for various other conditions. So regenerative medicine really can come from many things. The one that has the most mesenchymal stem cells and platelets and growth factors is bone marrow, but not all gynecologists are interested in obtaining bone marrow. You can also get it from fat. So plastic surgeons obtain this from doing liposuction and getting the fat and getting the mesenchymal stem cells. Us gynecologists, we can get this from platelets and from the blood, and that's where platelet-rich plasma is for. I also use amniotic fluid because I have it available in the United States, and I'm able to use amniotic fluid. And now umbilical cord exosomes can be obtained from the umbilical cord, and we have it in the United States now, and we have started using this in our therapies. I'm sure this will be available in India and other parts of the world. So let me show you the stack of blood. Let's say you took some blood and you put it in a test tube and centrifuge it. This top portion right here is platelet poor plasma, and this is the most anti-inflammatory portion of the blood. So this is what I like to use for things like lichen sclerosis and overactive bladder. I inject this on the base of the bladder, and I can reduce the hyperactivity of the bladder. This middle part right here has all the platelets and growth factors too. So the top part has the plasma, proteins, and growth factors, and 90% of it's water. This lower middle part right here has the buffy coat with the platelets and protein, but it has white blood cells. So it can be somewhat irritating, and it's not as good as platelet poor plasma to reduce inflammation and irritation. The bottom part here, red blood cells, it's not used in regenerative medicine. So these two right here are usually what are injected as PRP. So you mix the platelet poor plasma and the buffy coat, and typically this is called PRP when you mix them together. But again, you can split it out and just use platelet poor plasma for its anti-inflammatory effect. I'm sure you will have other talks on platelet-rich plasma. Some of the world leaders are from India. So it's been used for over 30 years. It's safe because it's from the patient, it's autologous, and it recruits mesenchymal stem cells. It's indirect therapy. It has growth factors and cytokines, and it can release proteins and growth factors from the platelets itself. Mitogenic, angiogenic, and chemotactic properties are seen with the use of PRP, and it's used for tissue regeneration, wound healing, scar revision, skin rejuvenation. It's used in lungs and eyes. It's used in hair, and I use this for lichen sclerosis quite a bit. So right here, you can see the different kinds of growth factors: PDGF, VEGF, fibrinogen, A2M, IRAP, and the platelets with the sacks of proteins, fibroblast growth factor, and TGF are all in the PRP. So these are all in there, and some will increase collagen content. VEGF will increase blood vessel formation, and so there's many different effects of PRP. And here's some of the benefits: creating neoangiogenesis. PRP helps collagenesis, elastogenesis, improvement in sensitivity, and it recruits stem cells. So those of you who are entering this field or want to enter will need to add a centrifuge and learn how to do PRP, because it can also be anti-inflammatory, and you can use this in inflammatory conditions such as vulvar vestibulitis, lichen sclerosis, and overactive bladder. The risk and downside of using PRP and PPP is that it doesn't work. It doesn't work for everyone, and as you age, it doesn't have as much growth factors and cytokines, and so it's age dependent. Once you get over, let's say 60 or so, it may not work as good. And those are the patients that I add things like amniotic fluid. If you use a kit, then you won't have sterility issues. But in many countries, people are just spinning it in a test tube and using non-sterile conditions. And so these are some of the issues that can happen. You can get bruising and hematoma, and those are just mild problems that can happen. So for regenerative medicine, I also use amniotic fluid. It's available in the United States. It's obtained from infertility patients that have planned C-sections. The amniotic fluid is obtained, it's sterilized, and then it's packaged and sent to us doctors. I think of it as booster rocket because it has such a high amount of both cytokines and growth factors, and it's consistent and not age dependent. And I like using amniotic fluid, and we use it here in the United States more and more. The product can be used by itself, or it can be mixed with PRP. It's highly anti-inflammatory, and it helps suppress the immune response, and it also recruits progenital stem cells. So if you have it available in your country, you should consider using that also. It's wonderful for, these are some of the conditions I've used it for. You can see here a lady here with very tender, thin skin from lichen sclerosis. I treated with radiofrequency. That's what TTCRF is. And I treated and injected PRP also, and you can see the improvement. And this is consistent. You can do this every year and keep the skin looking good. She had 3 treatments here. Another one is platelet poor plasma with amniotic fluid. You can see how inflamed this area is. You just touch it with a Q-tip, and it's very, very tender. After using platelet poor plasma and amniotic fluid, you can see the improvement in the condition. And we touch this up at least once a year, and the patient's symptoms are improved. It can also be used for, look at this area right here. We biopsied it, and it has a lot of blood vessels. And she had very painful intercourse. All this red area you just touch with a Q-tip, and she was very tender. And so we injected this area with platelet poor plasma, and we treated it with radio waves, and you can see the improvement of skin from year over year. And now we still treat her every year and keep her feeling pretty normal. Fillers in gynecology, you can use fat, or you can use platelet-rich plasma with hyaluronic acid. In Europe, a lot of hyaluronic acid is being used, and Europe is the leader in hyaluronic acid use. They're way ahead of the United States in terms of acceptance and the science, and that's something that you guys can use. Now, this coming month, I'm going to release a product called Gynexa, Gynexa. What it is platelet-rich plasma with hyaluronic acid. These are 15, right here are 15 cc tubes. It'll either have 2 cc's of HA or 3 cc's of HA. You can see here, this is a test tube, a gel separator, and down here is hyaluronic acid, anywhere from 2 to 3 cc's. The kit has the needles to draw blood. It has everything you need to do these procedures. And then you put it in a centrifuge, and the patient's blood is mixed with the HA, so you can inject both hyaluronic acid and PRP together for conditions such as lichen sclerosis. And this can also be used on labia majora to give the labia majora volume and improve the appearance, so it's not so saggy. So if you want to use fat, these are some of the things you can do. You can inject this area with fat, or you can inject it with the hyaluronic acid and the PRP. So I'm going to show a video. This is about a 12-minute video on how we do some of these procedures, and I hope hopefully you enjoy this. So I'm going to be quiet now, and the video will play with my voice on it. We have a great patient today, great case of a patient with a long history of lichen sclerosis, not diagnosed for a long time and finally biopsy proven. She had lichen up here in the clitoral area when we first saw her about 2 years ago, also on this right wall, and down here you can see some areas that have actually been treated and biopsied multiple times in the past. Treatment with both radio frequency and with platelet-rich plasma, and I can't remember if we tried amniotic fluid, probably platelet-rich plasma, have been able to control these outbreaks. And now 2 years later, we're having another outbreak right here where the skin is very thin, irritated, and right here during sexual relations it tears a little bit. The irritation today is in this region and this region, and we are looking quite normal up here. This used to be a very white, tense skin, and we used to tear easily down here also, but now it's not as bad today. But the irritation here is worsening, and we want to treat this before it gets any worse with both radiofrequency and platelet-rich plasma, which has worked for her in the past 2 years. So tell us your experience. What have you actually experienced in the past couple of years?
At the time that I came to see you, I was really devastated that there was no cure for lichen and no treatment that didn't require such invasive procedures. And through this process, I have learned that we can be non-invasive, work with my body, and really come up to a great result.
So you've been more comfortable now since we started treating you than the prior 5-10 years? Oh, that's fantastic.
More comfortable, but more importantly, my quality of life is much greater. I wouldn't have even risked a sexual relationship, anything like that. Now I feel like I can be in a sexual situation without feeling just tremendous pain.
And you told me earlier the thing that you learned most in the past 2 years is when to come in before it gets really bad.
And when to learn to listen to my body and see when the flare-ups are coming.
Okay.
And not ignore them.
Fantastic. So what we're going to do today, we'll show it very briefly, is I'm going to treat this area with radio frequency. This is radio frequency at 640 kilohertz, and this will help thicken the skin, bring in new collagen, new elastin, improve the blood flow. We haven't done this in probably a year. Last time we did it was quite a ways back. And so we're going to try to improve your skin again.
Yeah, it was last summer.
Yeah, last summer with radio frequency, and then do our platelet-rich plasma injection. So I won't show the whole thing, but go ahead, Cindy, put some gel up there, and I'll use that as a reservoir for down here. Oop, it's rolling down.
It's really hot.
Is that really warm?
I've got a lot of heat in it right
You got a lot of heat. So Cindy, can you wipe some of this off so it's... Okay, so down here, is this comfortable enough down here? Okay, we'll remove some of that. All right, so I'm gonna treat this area. I'll start at about 35 degrees, 37 degrees, because she's really tender right now. And I'll try to bring this up to approximately 42 degrees. We're at 36 now, and we'll slowly bring that up. Okay, so I'm gonna go treat this area for the next 10 minutes, and I'll concentrate on the areas that are irritated, mostly here, down here, perineum, introitus, a little bit on this left side of the patient. So we're gonna try to get that to about 42 degrees or higher for the next 10 minutes. That's given you some relief, and I have a little bit of local anesthetic in the PRP. So here's a little burning first, just on entry. Are you okay? Okay, I'm going to advance it a little bit. You're doing great.
Are you going to do much more recording? We're going to have to switch back.
Is our battery that dead?
Third one. Your mic. Just your mic, not the
All right. Okay. So I'm going to go up this. Actually, let me go down this way. This is numb already, so I might as well get this under your skin here on your perineum. You okay?
Mm-hmm. You might have to do a voiceover on this.
Did it just die?
It's just blinking and I'm not too confident.
I'll go ahead and speed up here and show how we inject on all the areas that are pale, and especially on the patient on this right side is where she had the most irritation. So I went ahead and injected this whole area with the platelet-rich plasma, and we put amniotic fluid in here also. All right, so you infiltrate this whole area, and I have about 7-8 cc's here, and I go up on the sides all the way up here. And then was it going all the way in?
It's going into that, just into that groove.
Right here. So, okay, so I'm going to go in here just a little bit more. I have 1 cc left, so I'll try. Opening on her left. All right, I'm going to move it forward to save us some time, and then I want to show you how it looks over time, how she's improved. Before we did our procedure. Let's go ahead and hear. This is how it was. This is how it looked like before we did our procedure today. You can see the skin is white, pale, itchy, and this actually tears a little bit when she has sex. This is how it looks like immediately after our injections. It's a little more pale. The PRP is in place. Let's go look back over the years. This is 2018 when she first presented to us. Red, inflamed, very tender, quite painful to touch actually, and both sides were quite red and tender. And there were some pale areas that we biopsied, and you can see here a few of the biopsy sites. We biopsied several more sites actually around the clitoral area, and you saw the pathology results. Over the years, like in 2019, she flares up, and every time she flares up, we take pictures, and this is how it looks like about a year later. And then another year later, it flares up in a different region, the clitoral area, the hood area on the left and on the right side. So it's a different place when she flares up almost every single time, except for this area on the right side. This is how it looks like before we treated her, and then 2 months after we treat her, the tissues look quite normal, and then 3 months later, she is quite comfortable and doing very well. We'll keep doing this over the next few years. So those are some of the things that you can achieve with regular use of platelet-rich plasma and amniotic fluid. Now, I want to introduce you to another technology. This right here is called predictive permeation or dermoelectroporation. This is the old term, dermoelectroporation. This device and the handpiece open up the water channels of the skin. These are water channels here. The rapid change in polarity, it changes from plus, minus, rapidly 1,000 times or so per second, and it opens up the water channels, and it enables pushing of products underneath the skin without injection. So this is what I use in my office. For example, I use numbing cream to numb up the area before a procedure, or I'll use this device to push PRP or to push amniotic fluid under the skin. So this has been approved by the FDA as an alternative to injections. And I love this device because I don't have to inject everyone. Here on this picture, I'm dripping in the PRP for lichen sclerosis, and I don't have to inject it. So those who have superficial issues, you can just drip it in without injecting. So you can push exosomes, you can push amniotic fluid, you can push hyaluronic acid, collagen, vitamin C, and you can even push Botox into skin areas without needles. So that's a technology that has been quite useful in my practice. Post-treatment for these patients, I'll use either growth factor therapy or carboxy therapy. It's available as a maintenance for my patients. Carboxy therapy is wonderful also. It rapidly changes the blood vessel formation in vulvar and vaginal skin. And this is also like rocket fuel for vulvovaginal tissue. If you have it available in your country, it's called CO2 Lift V for vaginal use, because they have one for facial use. And also you can use vaginal diode lasers for maintenance. For those with stress incontinence, we have devices that they make your vaginal tissues contract in like a electrostimulation for improvement of stress incontinence. And there's also even products here now called O2 Vask that I did the study in my office that use L-arginine, fenugreek seed oil, menadione, and spilantol extract to increase the localized vascularity. You can see here pre and post, and a lot more blood flow in these areas. And this is used right for about 15 minutes before sex to increase the localized blood flow, and this may help couples also. Also, now we'll switch to a different technology, high-intensity focused electromagnetic technology, or this chair here. Many of you have heard about this already. A powerful magnet is placed underneath the patient's pelvis, and it results in supramaximal muscle contractions, and it does about 12,000 contractions in about 28 minutes. Dr. Barinholtz and Dr. Samuels and myself did the studies in the United States on this to help stress incontinence, overactive bladder, mixed incontinence, and failed prior surgeries, failed slings, failed pelvic reconstruction type surgeries. And so we treated patients, but excluded pregnant patients. We excluded patients with urine infections or have active interstitial cystitis flare, and we excluded patients with metal in the pelvis, because remember, it's using magnets. Patient with pelvic pain also we excluded, and those with levator spasm we excluded, because this makes the contractions 12,000 in 28 minutes so hard. Those with pelvic pain and muscle contractions, this is not the treatment for them. This is for the overactive bladder and for the stress incontinence patients. So what it does is depolarizes the pelvic muscles right here. It makes it have the supramaximal contraction. You can see the contraction, and you can see the pulsation of the magnets that then make these tissues quite strong, contracted, and it's pelvic physical therapy with your clothes on, sitting on a chair. So we are able to use these non-surgical treatments, RF, growth factors, PRP, diode lasers, high-fem for our gynecologic patients. Now I'm going to switch gears again and go to surgical treatments such as labiaplasty. So let's talk about this really quickly. It's done for cosmetic and genital asymmetry, to improve appearance, to help reduce the trauma from childbirth. It's also called labial reduction. Other terms are labiaplasty, designer laser vaginoplasty, or plastic surgeons use this term labioplasty. So this is the anatomy of the labia, and this is the reduction. Labiaplasty is to reduce the size or improve the symmetry of these labial tissues. And so the new term that I wanted to introduce to you is, here's the frenulum, here's the clitoris, and below the clitoris is the frenulum, this area right here. And this confluence where the hood, this is the hood, and the frenulum meet is the frenular crease. It's not in your textbook, but you're going to see this in many articles coming out in the future where the frenular crease is. And it's important to know where that frenular crease is, because if you're doing labial surgery, that is a landmark to achieve symmetry and where to start. So frenular crease is a new term, and I just wanted to introduce it to you guys. It's a wide range of normal labia. This is all normal. Nothing is abnormal about this. It's all range of normal. But some women want it more petite. Some want more comfort, especially those who are riding bicycles, riding horses, athletes, patients with painful intercourse. So this is all normal. This area is quite safe because the vessels in the labia are all small branches of the pudendal. There's no major big nerves. Here's the pudendal, and they're all small nerves that come in this area, and the risk of damaging them is exceptionally low. And I've personally not seen a reduction in sensitivity or problems with orgasms after these type of surgeries. The vessels are also very small in this area, and you have to take care of them. There's no major vessels, so it's a very safe area to go. The clitoral nerves go up and around the pubic bone and into the pudendal, and so the risk of damaging major nerves is very small. Just stay away from the clitoris, obviously. So I do these surgeries on patients who are over 18 who have pain and discomfort, or they don't like the way things look. And many patients of yours are going to be divorcees, patient with low self-esteem and want new chance and find a new partner after a divorce. You do have to screen for body dysmorphic disorder. I exclude for office surgery patients with severe anxiety, patient with narcotics use and intolerance to pain. These patients I'll take to the surgery center. And so I'm going to show you a video of how to do this in the office. I exclude patients with major medical problems. I'll take those into the operating room. Again, I'll review really quickly the major types of labiaplasty are wedge and a linear technique. The wedge surgery is done by plastic surgeons mostly, and their goal is to preserve the natural edge. They take a little V-shaped or pie-shaped area of the labia and then suture the edges together. And my personal opinion is to avoid this technique if you're a gynecologist, because it does take a lot of skill and experience, and it has anywhere from 10 to 20% wound separation rate. You can see here, this lady had a wedge. She had a wedge removed from this side and on this side, and you can see here the wedge separated. This little area looks like a Pac-Man. It's separated. That happens in an average of 10 to 20% of all wedge labiaplasties. I'd rather have zero complication rate. So 10 to 20% is too high for me, so I avoid this surgery myself. 10 to 20% breakdown. I use a linear excision where you're doing an excision downwards from both sides, and I'll show you this. It's awake under local, no IV. And you can trim just the edge. We call that a rim labiaplasty. You can remove the majority of it. We call that a hybrid. This is late term, and this is not in standard textbook. This is what I use because it's descriptive. And again, you won't find this in textbooks. And then if you remove most of it right here, we call it a Barbie look labiaplasty. Let me go back to it. And you can see here the degrees of reduction. Again, these are late terms. You don't have to use these, but my patients like these because it's easy to understand. So it's also called a sculpted linear excision. These surgeries, the rim look specifically, where you just remove the dark edges, have a natural look, and it's not requested very often in my practice in California. My California practice, the patients want more reduction here, but rim is probably more common in the East Coast and around the world where radical surgery is not requested as much. Here is a rim look before and after, removing the dark edges, leaving labia looking normal. And here is a hybrid look where you remove more tissues. You can see here, I'm removing more tissues. And here's a Barbie look where you remove basically all of it, including, in this patient, the anal skin tag. So you can see that very little, if any, labia is left. And in my practice, the hybrid and Barbie look are most requested. The Barbie look is the removal of all or most of the labia. It's not simple amputation. It's discussed as simple amputation in plastic surgery journals, and it's the most technically challenging procedure that labiaplasty can do in my practice. So this needs a master level procedure. You guys should learn this, how to do the precision excisions, and watch videos, get some personalized training. I use radio waves for my surgery. This is radio surgery, and these are the fine pinpoint tips. The little tips are the size of hair, so it's exceptionally precise. There's no IV. I use topical anesthesia, oral Ativan and Compazine, some Demerol or Dilaudid perhaps. I do the predictive permeation and push local anesthesia under the skin. And then I use an average of 4 to 7 cc's of bupivacaine, and then we do these surgeries. There are fewer disasters. There's minimal tension on the edges. The edges stay healed, and you can remove a lot of the dark labial edges. You can't do this with a wedge. And for long-lasting pain control, I use Exparel. I want to introduce this to you. This local anesthetic is bupivacaine coated in fat. It's a liposome coated bupivacaine, and the pain control lasts on average 3 days. So my patients, I do this surgery in the office. They go home without any pain, and with the Exparel, they can be comfortable for several days. So I'm going to play about a 2 or 3 minute video on how I do my labiaplasty so you can see how I do it. We have a fantastic case today where we will be doing a perineoplasty, a labiaplasty to a hybrid appearance. That's what you wanted, right? You told me. You changed your mind. And then a hood reduction. She has a great deal of asymmetry here with a lot of bulkiness with multiple folds. Really tricky here. 7.5 cc's. Okay. Let me know if there's anything sharp that you feel. And don't pull when you mark. So while it's relaxed, put your dots. There's a tendency to mark too aggressively on the patient's right side if you're right-handed. Lateral hood. And we'll start off here. Okay. Just follow my lines. Okay. That's good. Little touch. So this is how it looked before we did our tissue excision. Here's the perineum reduced, and here's the labia minora on her left, labia majora on her right, with the modification of this area. That was both under the hood A incision on both sides, but I had to remove a little bit of tissue there. Here's the hood reduction. You're through it. You just have to open it with your finger. Start at the top and just, yeah, it has to be touching. It has blood flowing through it. Now it's dry. Remember, it only works when there's... But that's right.
And you said you have a vessel, like
Mm-hmm.
that, and then
Right, exactly.
otherwise I go all the way down.
It's sticking right now because there's no blood flow. Okay?
Yep. Thanks.
Pretty cool, huh?
It's like circulating though, you know, barbiolabioplasty.
Mm-hmm. Would you like to know the history of that?
Mm-hmm.
I was working in LA in North, so that it stays down, I will grab it here instead of its edge. 11, 12, 1, 2, 3, and I'll do the anterior compartment for about 5 minutes. Her issues are more with overactive bladder, so I spend a little more time there. I'm going to start with your O shot, okay? Oh, I'm sorry, that video jumped to the very last video, so I'm sorry about that. I don't know why it did that. So let me go find that video again, and I'll start playing it at the very end. We were out here. After surgery. So I'll show you the results of this. I'll show you a little bit of the O-shot and fillers that we did. This is where it stopped, and I'll go ahead and do the majora and clitoral injections. Take this out. She did well. We didn't have any spill, and there's the whole CC. I had numbed this earlier, so another CC here. But you're okay with this right now?
Yeah.
Nothing lumpy. So let's take a look at what we have done for this patient. She had hypertrophy and asymmetry of her minora, and also had some redundant folds of her clitoral hood, especially on her right side. We gave her a little volume on her majora, and we shrunk the skin of the majora to give her a more healthy, petite, and youthful appearance. After surgery, she's healed up about 6 weeks later, and she's very happy with the results so far. She likes that she has a little bit of labia left. From the patient's point of view, it's dramatically different as she looks down. She does not see the asymmetry anymore. She's very happy with the petite look. She has some volume in her majora, and she's quite happy with the results. Thank you. All right, so that's labial surgery can be done in the office safely and without IVs. And the amount of labial reduction you have to discuss with the patient. Everyone wants it a little bit different. Now I'm going to show you a video of labia majoroplasty. I won't spend much time on the discussion because we're running out of time. This is a procedure that actually do more than labia minora in some months. There's a media-driven fascination of the camel toe where it's bulging out, and a lot of people don't like that. And so we do the surgeries to reduce this camel toe and so that it's not showing on the swimsuits. And here I am, I'm doing a consult here with this camel. I did that in Dubai. So there's a media focus on it, on the 20-year-olds, and they focus on primarily on the appearance. But in reality, it's more the 40 and 50-year-olds that have these type of surgeries, and it's on function and comfort. This is the everyday woman. This is not the Hollywood woman that gets these type of surgeries. It's for those who want it to look better, feel better, and not have to adjust that area or feel like they're chronically sweaty. They want to reduce this type of stretch on the majora. And I think cosmetic gynecologists should learn this procedure because it's actually easier than a labia minoroplasty. And let me show you this procedure. Our patient came in complaining of a camel toe appearance, so she wanted a labia majoroplasty with fat pad reduction, vertical clitoral hood reduction, and feathering of her labia minora. She also had reduced sensitivity, so she requested an O shot and PRP injection. She wanted reduction of fat in this area and reduction of skin in this area too. So we're going to talk about this surgery and demonstrate it for you on how we reduce this bulkiness of her majora, how to remove the fat pad, and also how to remove a little bit of the fat pad in the mons pubis area. So we start with predictive permeation on this patient. We'll numb this area in the office, and you can see here on the video, bipolar cautery, standard cautery. Now I'm going to give local anesthetic here. I'm going to speed up the video and show you how I inject. Here I am. I'm checking. I'm asking her, do you feel anything sharp, Mrs. Smith? I'll start with my markings. I find my medial, my middle portion. In the elderly patient with a lot of sagginess at the bottom, it may be pear-shaped. So this is about the right amount of tissue to remove. Now I'm going to, again, rely on the marks that I placed on the majora. You can see here I'm using my bipolar. So here, I'm trying to just remove the vulvar mucosa. There's two. Those of you who have not used Exparel, it's a bupivacaine that's coated in a liposome coat. And so that is the fat pad I'm going to remove. All right, so we'll just keep going here. And so here's the piece of fat that we removed. It's a significant amount. Okay, almost have hemostasis there. We're going to keep going here. And you can see up on top here, I'm trying to make it so that at the very top, it goes to a V up on top. So for this patient, I'm the final guy for her mommy makeover. So this is almost like a liposuction using electrocautery, removing this bit of fat here. On this same patient, let's go over this again. I removed the skin on her left side, and then after that, I removed the fat. On this opposite side, I removed the skin and the fat pretty much together. Again, here are the pieces of tissue. It's pretty significant. Have less bulkiness, have less sweating in this area. Again, don't remove too much. Just go to the top of the ridge and do some refinements if needed. So I'm removing just this edge of skin here to make it just a perfect fit for the patient. Place an anchor up here. You notice I switch over to monocryl. This technique will remove that top 2/3 crease. I try to make my knots to be below the skin level. It's a little tricky sometimes. Look and see, it looks like I'm still puckered there. I'm going to go ahead and do my anchor here for my subcuticular suture. Now I'm going to round out the edges of the minora. Instead, don't overdo it too much because the tissues will shrink. Okay, it's lining up pretty good. Video. But basically, you put loosely placed interrupteds. That's your third layer. One more area right there. It's pulling apart. All right, here we are. We're done with surgery. This is what we've removed for this case. Majora mucosa, majora fat,
and here all together, skin and fat together. Now I'm going to just go ahead and inject this area with PRP. Okay, she's numb, doesn't feel any of this. And that's pretty much it. If you remember, this is before surgery with a fat pad underneath. This is the skin that we removed on both sides, a significant amount of skin, and then smoothing out the labial edges so that it's more symmetric. It's starting to look more normal and equal, and this is about a month out, starting to look a little bit more normal. And this is a couple months after surgery where the edges of the labia look beautiful. The top portion of where the clitoral hood is now flat, and there's no more bulkiness. Patient's very happy and has followed up with us, and we have done several treatments with lasers for hair reduction at this time. We follow her every year. Thank you.
All right. So these are the things that you can achieve from a very bulky majora to a petite, more athletic appearing majora. You don't always have to remove fat. So this is in the patient who's in their 40s and 50s. Is the fastest growing segment of many aesthetic vaginal surgery practices. And you can do surgical and non-surgical, such as radiofrequency. It's safe in the office. And really, I feel it's easier to do than a minoroplasty, and with a high patient satisfaction. So the next thing I want to do, I'm running out of time, and thank you for being patient with me, is I want to just show you what in-office vaginoplasty is. I'm going to show you the video. I'm not going to spend a lot of time with the didactics here. It's for this procedure is for vaginal laxity and lack of friction from childbirth trauma. And we do this quite a bit in the office. It's very safe once you know how to do this. It allows you to do these procedures on your time and not be at the mercy of the operating room or the surgery center. It increases the friction, improves the appearance, reduces the gaps, improves patient confidence, and the risks are anesthesia, bruising, bleeding, occasional wound breakdown, just like a posterior repair, the same kind of risk. And so these are things that you must discuss with the patient. The tools are simple, similar to what you need for an anterior and posterior repair. The Lone Star retractor is necessary to do this in the office. This is a patent of mine from about 14, 15 years ago, and I use the yellow hook. So let me show you this. You have to numb up the perineum under the vaginal mucosa. You have to numb up the superficial transverse perineum, and you have to learn how to do a levator and a pudendal block. Not just the pudendal, you have to learn how to do the levator block, and you have to do this to do the procedure. So here's about a 3-minute procedure. I'm going to speed through this because of time constraints. So this is the patient with the small rectocele. She wants a labiaplasty also, so we're going to go ahead and give local anesthetic. I'm checking to see if she's numb. I put my Lone Star retractor. I put more numbing so that the hooks are placed, and then I'll go ahead and put my levator and pudendal block. I'm identifying the ischial spines. I'm placing my spinal needle right beside the ischial spines, and I'll inject above and below the ischial spines, both on the left.
But I added
Both inject on the left and on the right side. And then I'm going to do my markings to give me an idea how much reduction of perineum to give her appearance of a virginal appearance, and give her not just a better appearance, but tightening also. I'm going to use local anesthetic right underneath the vaginal mucosa. Remember, this patient is awake and talking to me. And once I give her the numbing, I'm going to do the dissection, and I'm going to use my electrocautery and dissect right in the middle here. And I'll use my T-clamps here to pull, and then I'll do blunt and sharp dissection. You can see I'm using a gauze sponge and pulling and identifying the levator muscles on each side. I'm going to go ahead and play this, and you can then see what I do to do the dissection and the suturing.
Here's my arcus tendineus right there, right below that. This is all levators. That I bet you that's an enterocele. And here's the rectocele. Here's the break. Way down here above my finger.
feel like you're tugging on something.
I am tugging.
Like you're tying a shoelace.
I'm going to identify my anatomy one more time. I like doing it before I put in every suture. So here's my arcus. This is all safe. Rectum is under my finger. You're doing good. These are the number one side of failures when the perineum isn't supported during these type of repairs. Okay, let's see if we close that defect up there. So now she wants to be 2 fingers tight, so I'm going to have to trim all this straight that way. Okay, there's the vaginal mucosa. From there, straight across. All right, so that's 1 finger tight. That's 2 fingers tight. So this is what we've accomplished so far. We did a vaginoplasty and perineoplasty. And we removed a great deal of vaginal mucosa and got her from about 4 to 5 fingers wide to 2 fingers wide. We did the labia majora and minoroplasty in a unified approach. They're both there, minora and majora. And on this side also, minora and majora. Let's take a look at our patient's history over this past year. She has majora laxity, she has a labia that she does not like, she also had the pelvic prolapse, if you remember. She had a rectocele that was quite prominent, and we found an enterocele also, and she had bowel function abnormalities, and we found this rectocele here with a perineocele, and after surgery we were able to tighten it quite a bit and get her to the 2-finger breath tightness that she wanted. Post-operatively, this is how it looks after I did a labia minora and majoroplasty and hood reduction also. And she's puffy here at 1 week out, and now that she's about 2 months out, she's very happy and petite in appearance. She's very comfortable with this, and now she's able to have comfortable relations and have more friction that she can feel. It looks very tight here, but when you examine her, she's 2 fingers tight, just like she wanted, both in the horizontal and vertical dimensions. And if you look inside her vagina, there's no more rectocele, and it's full length. If you remember, this is how it looks before we did surgery, and after surgery about 2 months later, she's quite petite and happy with her results. We can do some minor revisions here, but in general, she is quite happy. Thank you.
All right. So if you are thinking of going into this business, you have to start thinking like a plastic surgeon, and you have to remember that function and appearance are both very important. You should get paid what you're worth. And we, in our practice, and most practices that do this in America, we don't take insurance for this. Go get a textbook, get trained online and on-site. Find in your country training programs. Dr. Sejal Desai has a great training program in India. She's a graduate of mine. Join Gyneflix, learn from my videos. This is something that is not new. There's a big demand growing, and we're just at the beginning of this growth of this field. And so with that, I want to introduce you to my cosmetic gynecology e-learning called Gyneflix. I started this just 2 months ago, and we're putting all our 20 years of videos in 4K and HD on gyneflix.com. I have my recorded webinars, my training videos. It adds newsletters and my library, and it also has my webinars and a lot of resources for the doctors. You can learn about gynecologic photography. You can learn specifically on perineoplasty or specifically on vaginoplasty. You can even do searches. For example, if you do a search on Barbie labiaplasty, you can find that there are 14 videos on it. And now there's over 40 videos. I've expanded the library. So you can search specifically on what you want to do. If you want to do O shots, you put it in there and all my O shots videos will show up. All my majoroplasty or vaginoplasty or my lichen sclerosis treatment videos will show up. There's over 200 videos. You get a free listing on vaginalrejuvenation.com to help you with your marketing so patients find you. You get free subscription to my cosmetic gynecology and feminine wellness newsletters. And I encourage you to all join this because I spend a great deal of time and energy placing quality content on these newsletter, and it's very inexpensive. It's only $98 a month. And for those gold members who want help with forms and templates and marketing, it's only $198 a month. And you get access directly to me. You get an email directly to me. You can text me, Zoom me, or FaceTime me at this gold level. And so you have access to my knowledge and myself. So for this year, for 2023, we're going to add the vaginalrejuvenation.com. We're going to create a Gyneflix for women for education of the public. I'm going to put all my best photos to be accessed on the website. We're building that right now, and I'm in the process of building an atlas so you can have the photos and videos all in one place. And with that, I want to thank you very much for sticking with me. I know it's a lot of content for the short amount of time, and I hope this has been helpful for you. Thank you very, very much.
Thank you so much, Dr. Allison, for sharing your great expertise and knowledge with all of us. It is open for the discussion. The one point which I want to say to all the viewers, that whatever the discussion is, cosmetic, aesthetic, regenerative, and functional gynecology is going to be stay there. And it is really a boon for many, many women. And a question arises when we talk about the developing countries or socioeconomical poor countries, how much it is relevant. Yes, it is relevant. A woman who is having a problem, she's being on a stress and she's not fit for the surgery because she's a very, very mild stress incontinence. She has a dragging sensation. She has specifically the older woman who is having a atrophic vaginitis, they are going to be improved a lot with this technology. Thank you so much, Dr. Allison. It is open to all for the discussion.
Thank you
to
so much.
persons.
Thank you, Ragini ma'am. And thank you, Dr. Ellen Sod. It was really a treat for everyone to watch. And I would like to invite now the Dr. Farooq Zama for his questions and expert comments on the topic. If sir is not here, then I can see Dr. Farhana Diwan. Ma'am, please do the honors.
Yes. Thank you so much, Dr. Sheila. I think that I was really very, very much benefited myself. Dr. Red, I would like to thank you especially for showing such beautiful videos and so self-explanatory and so simple. And I think that the women in need and women in distress will be very much, I think they are benefited because you have been constantly talking with them and you have been telling us that you are doing this procedure yearly and all that. And you know, the lichen sclerosis one, it was very nice and we learned a lot. But the other case where you did the fat reduction, I think that was really something. And when we do the vaginoplasty, sometimes we do the local vaginectomy in cases of small lesions in the vulva. So in that case also, because there's nothing below the fat and the vulval skin, there's nothing, no structure there. So you can easily take up the fat. And sometimes this fat also we use when we do the fistula surgery, we use this fat for a graft. So that is the thing, we are using this for different techniques. But your fat removal and the reconstruction was really mind-blowing. I'm so happy to see it, and thank you so much. Thank you very much, sir.
Thank you. And you know, it is doable in the office. Everything you saw there was in the office by myself, no assistant, just me and my medical assistant, who sometimes scrubs when I need retraction. But no, this is all done solo in the office. You can see with the right equipment, the Lone Star retractor, you can do it by yourself. You don't need anyone else.
Thank you, sir.
Yes, sir. That's why we adore you so much. Everyone was hooked to the screen while you were explaining and talking about all the procedures. We have pleasure of having Dr. Ratnasri also. Sir, we would like to have your comments also. So please unmute yourself.
Thank you, Right, for your 20 years of revolution of what you have done over the years out of box of our traditional medicine. What we do with surgical procedures and hormonal therapy for most of the silently suffering women. So I actually learned a lot from you what you have done with office gynecology as well as the inward, in the sense, in theater. So you have used lots of energy-based therapy, laser, radio frequency. So they are traditionally, actually, we are not with these kind of therapies in our setups. Most of the time they are new to us, but I can see how much you can do differences and the treatment therapies with this kind of therapy. But it's interesting to see the PRP, amniotic fluid, and the hyaluronic acid, how it has changed over the years and how it can, I think, some kind of stem cell therapy type of therapies have changed. It's mostly for the valvular rejuvenation. I used to change the terminology to rejuvenation to regeneration. So I think that is very much interesting. So I think most of these therapies may be a little expensive, but it may be available soon, or the areas especially like carboxytherapy, oxyvax, and all this labial rejuvenation. That is also very interesting. I think some of the women suffer silently, but they don't come out. But they don't have a chance of getting these surgeries in the traditional way. So I think this is very interesting. So it's a good eye opener for all of us and make it available for our women in the region. Sometimes may be a little costly, but still it should be available. I think. Thank you very much for eye opening this cosmetic aesthetic regeneration, gynecology, surgical and non-surgical procedures. Thank you, Raj.
Thank you. Thank you very much.
You.
It does not have to be expensive. You don't have to buy the expensive toys to jump into this field. If you have a centrifuge, you're able to draw blood, you can do this. It's not expensive. And those of you who do pelvic reconstruction already, do anterior and posterior repairs, you have all the tools that you need. And so it does not have to be expensive. You don't have to buy expensive radiofrequency or laser device to cosmetic gynecology, because many of the tools you're already using. You just have to learn the skills on how to use them.
Sir, before we take comments from Naren Malhotra sir also, we have one question from the audience that how do you sterilize amniotic fluid for this use?
I use amniotic fluid for addition to PRP for those who are elderly and don't have good growth factors or cytokines in their blood. I will add amniotic fluid as a booster because it has a lot of growth factors and cytokines, anti-inflammatory cytokines. And so I'll use this onto the base of the bladder, either by itself, amniotic fluid by itself, about 4 to 5 cc's. You actually use only 1 cc of amniotic fluid and mix it with about 5 cc's of injectable saline, and you inject it onto the mid-urethra, just like you're doing a sling or an anterior repair. One puncture site in the mid-urethra, and you inject it, and it dissects out underneath the bladder through the one injection site. And as it dissects out, it will cause an anti-inflammatory effect and reduce overactive bladder. And I also use the same solution on lichen sclerosis. You saw on the video how I injected right underneath the lichen sclerosis. That will cause increase in formation of new collagen and elastin and reduce the irritation of lichen sclerosis, and probably control it for an average of one injection can control it for about a year on average. And those with very thin skin, I add hyaluronic acid, a filler, onto the PRP. I mix it together, and you can also add amniotic fluid and inject it together as one injection, which is what I did on the first video.
Okay, thank you so much, sir. And sounds awesome. And we look forward to hearing some expert comments from Naren Malhotra sir also.
So thank you, Professor Red Allensort, for your wonderful exposition to the Asian countries on cosmetic and aesthetic gynecology. Yes, these things are catching up in India, and we are now having the Indian Society of Aesthetic and Regenerative Gynecology, which was founded in 2019 with me as the founder president, and Dr. Ragini is the president now. And so we do have our own association, which has been affiliated to the ISAC. Dr. Badr was here in Agra doing a training. And first you were in Agra. I mean, cosmetic gynecology in the Foxy conference was first introduced at Agra in 2016 when we did a full workshop here with Dr. Red Ellensott. So that is where it came all started from. And using PRP, amniotic fluid. PRP we've been using widely, and amniotic fluid. After hearing you just last month on amniotic fluid, I've just started you mixing amniotic fluid, and let's see how it works. So thank you again very, very much. And that's his email ID in the chat box. So those who will, want to talk to him can do that. And do subscribe to Gyneflix. And that'll teach you that. Then you don't need to go anywhere to USA to learn. And he's such a great man that he's put all his teaching videos on Gyneflix. And that is a wonderful, wonderful initiative. Thank you, Red, for being here with us. And sorry to wake you up at 5 o'clock in the morning, but we all enjoyed here.
Thank you very much. So feel free to contact me. I put my phone and my email there. And thank you for considering joining Gyneflix. All my best videos and my training are there. And I'll help you guide you through this field. If you have an interest, I'll personally help you. I love my Indian colleagues. And since my first trip there in 2016 and talking about this, it's been great. I'm so happy that my graduates, such as Dr. Bader and others, have been teaching there. We do love teaching excellence in our program and creating leaders worldwide. And I'm sure many of those leaders will come from India.
So we've done a lot of workshops with Badr in Agra, with Carolyn, and with Ronan Gold also. And this year, probably we'll have you also. Hopefully we're planning one in September, October to have you again in Agra or anywhere, or a couple of them all over India under the Indian Society of Aesthetic and Regenerative Gynecology.
Well, it's a pleasure to be with you. Thank you very much. And I hope we get to meet each other in person in the near future.
So there are two questions.
Okay.
There are two questions. Doesn't the patient feel dyspareunia after the surgery?
For the vaginoplasty, they can feel dyspareunia if they don't do any vaginal softening exercises. So all my vaginoplasty, perineoplasty will perform 2 weeks of massage therapy right at the opening. They'll use estrogen cream and massage with their thumbs first for about a week, and then they'll go to a vaginal dilator and massage for a second week before we allow them to have sex. And that reduces your chance of dyspareunia dramatically. So the incidence of dyspareunia is low, very, very low, if you use your softening exercises. I have a video on it. I have an instruction sheet on it, and we tell the patients that they must do this before they're sexually active. So we preemptively try to prevent that. We also like injecting PRP in that area, so it helps reduce the formation of scar tissue, and that's been tremendously helpful to reduce the incidence of dyspareunia.
The second question is, how do you procure amniotic fluid? Those who are delivering babies know how to procure amniotic. They're having bath in amniotic fluid every day, probably. So you just correct for that.
Yes, in the United States, it's collected at the time of C-section, and then it's bathed in antibiotics, and all these patients have been cleared because they're infertility patients. They've had all their blood tests to check for HIV, hepatitis, and things like that. And then it's collected and then packaged by a company. We can't, in the United States, we can't just get it from a C-section and start using it because it hasn't been filtered. There's a risk if it gets intravascular, you get DIC or lung issues. So it has to be filtered and cleaned, and I believe there's gamma irradiation at times. So you can't just get it from a C-section because that could be dangerous.
Thank you. Thank you. I think we can request Yusuf Latif to say the word of thanks.
Thank you very much. I appreciate it.
Okay.
Dr. Yusuf Khan is Secretary General of Safog and Professor in OBGY in Rashid Latif Medical College, General Secretary of Society of Gynecological Endoscopy, and he is also Scientific Secretary for IVF Society of Pakistan. Holds a special interest in high-risk ops and reproductive medicine. So, sir, we request you to kindly deliver a vote of thanks.
Okay, thank you very much, everyone. It's a pleasure listening to this for the last, I think, about 2 hours or so. But compliments to Dr. Red for getting up early, so much early in the morning, and making sure that we don't even sleep during all this process. And this is one of those things which normally we general gynecologists kind of sway away from that, and it's a kind of a subspecialty, and which is a need for a lot of patient requirement to that. So we would love you to also come to Pakistan as well, because I'm sure there are a lot of patients who will kind of benefit from all these simple procedures which are there. And hopefully, if these simple intervention can change the life of a patient, then it's immaculate for everybody around. So thank you everyone for being there, and it's a pleasure to listen to everything. And it's kind for me especially, it was, as Dr. Malhotra always said, I always tell him he brings back things from Star Wars or the future and everything, and we sitting here then kind of learn from that, and we can benefit them for a long. So hopefully, Professor Ed, we'd love to have you here in Pakistan as well. If you plan to come to India, let Dr. Narendra know. He can always arrange to just toss you over to our side as well, so we can benefit as well. So thank you very much, everyone, and it's a great and pleasure to see everyone. Okay, take care, bye, and stay safe.
Thank you, Dr. Khan, and thank you, Rohana sir. Thank you, Ragini ma'am, and foremost thanks to Naren Malhotra sir and Professor Red. We are your fan and would love to listen to you again and again, as Malhotra sir said, in India soon. So, and thank you everyone for joining. Thank you, Shield Connect, for all the. Ma'am, you want to say something, Ragini ma'am?
No, bye.
Okay. So thank you so much, everyone. Good night. Take care and stay safe.